Okay, so we're going to be talking about stroke today. Before we get started, as always, I wanted to thank you so much for the support, the likes, the comments, the new subscriptions. I really appreciate everything. When I hear on a comment that something I made in one of the videos helped you on an exam or on your boards, just makes my day. So thank you so much for that. Let's go ahead and get started with stroke. We're going to start with our TIAs, our transient ischemic attacks. I'm going to keep this kind of brief. There's not a lot of high yield stuff from TIA, just a few things to be aware of. So TIA stands for transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. That's the key. That's the official definition from the American Heart Association and the American Stroke Association. So a TIA, it's a clinical diagnosis. It's often not the easiest diagnosis to make because the presentation can be highly variable. There's many differentials to consider, and often by the time the patient presents to you, their symptoms have resolved. But essentially, a TIA looks exactly like a stroke in presentation, but the symptoms resolve, they get better. And then the key is that there's no tissue infarction or tissue injury. So to put it really simply, a TIA, there's a clot in a vessel, causes some transient symptoms, but it dissolved fast enough that it didn't lead to death of brain tissue. One thing that I wanted to mention, you may have heard that a TIA, it's a focal neurologic signs or symptoms lasting less than 24 hours. You may still hear it being talked about in clinicals, with your preceptor. This was something that was used long ago before we had MRI neuroimaging. The de-emphasis on duration really came after multiple studies showed up to 50% of classically time defined based TIAs actually showed brain injury on MRI. So you had these patients, symptoms resolved in less than 24 hours, so by the time-based definition, a TIA, but when they actually had an MRI done, they showed stroke on their MRI and infarct. So kind of get that time-based definition out of your head and focus more on the newer tissue-based definition of a TIA, which is lack of tissue infarction visualized on neuroimaging, MRI, etc. Now let's talk about our history and exam. Now with a TIA, usually the symptoms are really brief, often lasting just a few minutes, and by the time the patient gets to your office or the ER to see you, most of the time the symptoms have already resolved. So a lot of the actual exam is getting a good history. We will talk more about the specific symptoms when we talk about stroke in a minute, but for TIA, there's really two things that you need to be familiar with that I'm going to go over. These are the ones that always seem to come up in exam questions, and that's amaurosis fugax and carotid bruit. So amaurosis fugax. This is a transient monocular vision loss. This is a big one because it always seemed to come up on exam questions referring to a TIA. There's obviously other causes, but if you see this in an exam question, right away be thinking TIA. And so what happens is when you have an occlusion or stenosis of the internal carotid artery circulation, this is going to lead to hypoperfusion of the ocular arterial circulation. So basically, your carotids are clogged, your eyes aren't getting perfused, this temporarily shuts off the lights. That's amaurosis fugax. In a vignette, the way you're going to see this, it's going to be described either as a curtain coming down in front of their eyes or a generalized darkening or shadow in one eye. It can last a few seconds up to around 30 minutes. But if you see this on a vignette, very, very likely TIA is the answer. The other one that I wanted to touch on is a carotid bruit. So on physical exam, auscultate the carotids. You hear this turbulent flow through the carotids. This can be due to atherosclerotic plaque in the carotid arteries that cause stenosis, and it can be both a major cause of a TIA and ischemic stroke. So beware of that too, because it's very common to see that on your vignette, on your exam questions. Talking about diagnosis, I'm going to briefly run through the diagnostic tests because the workup is really very much the same as in stroke, which I'm going to go over next in more detail, and I'll talk about the diagnostic tests at that point in more depth. But the idea is you start with your neuroimaging in suspected TIA patients. So neuroimaging, MRI, CT. So early brain imaging with MRI or CT is indicated for all patients with suspected TIA. MRI actually has a greater sensitivity than CT. But the problem is with MRI is it's time consuming, it's expensive, there's contraindications. So CT is an alternative if MRI is not available in certain patients. Also your neurovascular imaging, so MRA, CTA, carotid ultrasound. It's really important in patients with a TIA to rule out an obstructive lesion in a large artery supplying the affected territory. So when you image the vessels of the brain and the neck, you're looking for your source really. Do you have an intracranial atherosclerotic disease or do you have carotid stenosis? Once you find your source, you can direct your secondary prevention at that atherosclerotic disease, or you can even intervene with a carotid endarterectomy, for instance, which we'll talk about later. So that's your cornerstone of your diagnostic workup in a TIA, and that's what I'd memorize for your exam, your neuroimaging with CT or MRI, your neurovascular imaging, MRA, etc. You also have your ancillary testing though, so like EKG to rule out, say, AFib, echocardiogram, where you'd be looking for a cardioembolic source for the TIA, lab testing to rule out metabolic and hematologic causes. But the main workup, brain imaging, neurovascular imaging, focus on those for your exam. Treatment. Big one, antiplatelet treatment, aspirin or aspirin plus clopidogrel. It's really important, probably the most important intervention to remember for TIA. For almost all patients with the TIA who do not have a known cardioembolic source, so not from AFib throwing a clot, we start antiplatelet therapy. This can be with aspirin as monotherapy or dual antiplatelet therapy, aspirin, clopidogrel. All depends on the risk score, so remember that. If they have a cardioembolic source, you're going to use anticoagulation. So if they have AFib, you're going to start them on oral anticoagulation with warfarin or a direct oral anticoagulant to prevent future emboli. Another treatment option for the carotids is going to be a carotid endarterectomy or carotid artery stenting. So if you see on neurovascular imaging, patient has significant carotid artery stenosis, specifically internal carotid artery stenosis of 50 to 99%. You're going to intervene with a revascularization of the carotids, which can be done via an endarterectomy or carotid artery stenting. Let's take a look at what a carotid endarterectomy is. It's a procedure where they make an incision along the portion of the carotid artery containing the plaque. They cut out the plaque, suture the artery back up. Remember, this procedure you're only going to use in patients with significant stenosis, 50 to 99%. Also, you want to try to reserve this for patients with a life expectancy of over 5 years. So some of the guidelines for that. The other thing to remember is your intensive risk factor management. So hyperlipidemia, hypertension, diabetes, smoking cessation. So the big thing is with a TIA, the patient got a warning sign. Not everybody gets so lucky. So these patients need to make some significant lifestyle changes to prevent recurrence. So effectively treating their hypertension, getting them started on high intensity statin therapy to lower their LDL, smoking cessation, limiting alcohol consumption. If they're diabetic, improving their glycemic control. You need to reduce their modifiable risk factors to help reduce their future stroke risk. So for treatment, just kind of wrapping it up, two most important things to remember: antiplatelet treatment, aspirin, clopidogrel. That's going to be most of your patients with the TIA, and then reduce modifiable risk factors. That's the cornerstone of TIA long-term management. Let's talk about one last thing for TIA. It's called the ABCD squared score. So UpToDate, quote unquote, puts this as a simple but suboptimal assessment tool. So this test is far from perfect, but it's still being used. You'll likely hear about it. So I just wanted to give you a general idea of what it is, what it's used for. So the ABCD scored helps you determine a few things. So the thing is, when a patient has a TIA, they're at a really high risk for stroke. So this calculator is going to help you assess how high the risk is for stroke in the near future. This score also helps you to determine how aggressive the treatment needs to be for these patients. So for instance, determining whether or not to use monotherapy with just aspirin or dual antiplatelet therapy with aspirin plus clopidogrel. Plus, it also helps you to determine if the patient in your office today is going to get the full $1 million TIA workup, or do they more likely have just maybe say a complicated migraine, and maybe that you don't need to do every diagnostic test in the book. So calculator helps guide you with those types of things. Again, it is not perfect. And the other thing that I wanted to mention is do not memorize this. I want you to be aware of it. I'm just going to show you it really quickly so you kind of understand what it is, but don't memorize it. There's no value in memorizing this for your exams. You just look it up when you have a patient in clinicals, but don't memorize it. So this is what it looks like. A few different things. Each is worth a different point. If they're 60 or over, they get a point. If their blood pressure is 140 over 90, they get another point. Clinical features, if it's unilateral weakness, 2 points. Isolated speech disturbance, 1 point. Duration of symptoms, you can look at that. They have diabetes, it's another point. And then you look at the bottom, calculate their score, and then that calculates how high their risk for stroke is in the next couple of days, which helps determine those things we went over. So again, that's your ABCD score. Don't memorize it, just be aware it exists and kind of know about it if somebody mentioned it maybe in clinicals, so you have an idea of what it is. All right, so what do you need to know for TIA? There's a few things I want you to take away. If you're going to forget everything else, remember these 3 things. Remember, transient episode of neurologic dysfunction caused by ischemia without acute infarction. Remember your amaurosis fugax, that's the one you'll likely see in a vignette. And then remember your antiplatelet treatment like aspirin, because that's going to be used for most patients. All right, that's TIA. Let's move on to our stroke, the star of the show. There's 2 types of stroke, ischemic and hemorrhagic. Ischemic is your most common type, around 75 to 80% of all strokes. That's the one we really need to focus on because most of your questions will come from this. Hemorrhagic is less common. We'll touch on that at the end. Let's start with ischemic stroke. This is the one you need to focus on. So ischemic stroke is a sudden loss of blood circulation to an area of the brain leading to death of tissue and loss of neurologic function. So ischemic stroke, you have a compromised blood vessel, which leads to decreased perfusion, resulting in death of brain tissue. Remember when we talked about TIA, the clot dissolved fast enough so there was no brain death. In stroke, that's not the case. We have death of brain tissue. That's the key. Now with ischemic stroke, there's 2 different types. We have Thrombotic, which is going to be your most common type, happens when a thrombus forms in the artery walls. This generally happens when you have atherosclerosis in the vessel. Let's take a look at that. So you have plaque in the vessel. Let me just get my little laser pointer here. And something causes the fibrous cap of the plaque to shear off. So you see this little fibrous cap here. Something happened and this fibrous cap opened up, exposing the soft interior. And when that happens, is platelets rush in to close up that little area that opened up, and when that happens is you form a thrombus. So all of these platelets come to close this little opening up, and then you form this big thrombus here, and it forms around the plaque. This leads to occlusion of the blood flow distal to this area, and you have an ischemic stroke. So that's thrombotic. That's your most common type. Embolic is the other type. So embolic means the clot came from somewhere else in the body. It traveled from a distal site, got lodged in the vessel of the brain and occluded the vessel. Common cause of embolic stroke is AFib. There's a bunch of different types, but patient has AFib, throws a clot from the heart, clot gets lodged in the vessels of the brain, leading to stroke. If you ever forget which is which, like is thrombotic or embolic, where the clot's traveling from elsewhere in the body, I always just remembered embolic starts with an E. The E for me stands for elsewhere, meaning the clot came from elsewhere in the body. Just an easy way to remember that. All right, clinical manifestations. This one's really important. This is where a lot of your questions are going to come from. So different arteries supply blood to different parts of the brain. Different parts of the brain control different parts of the body. So you need to have a very basic understanding of occlusion of which vessel is going to lead to a deficit in which part of the body. This is important because this is likely going to come up. I had this on an OSCE. I had it on an exam question. They're going to give you the patient presentation. Maybe they're going to say they have left lower leg weakness. And then they're going to ask you which type of stroke this is. Is it middle cerebral, anterior cerebral, etc.? I do have some tricks for you to remember this. I'm not going to list every single symptom or deficit for each artery. I'm going to stick to just the very basics, enough for you to pick it out on a vignette. Let's look at the circle of Willis just so you get an idea when I go over the arteries what I'm talking about here. So we're going to be talking about the anterior cerebral arteries. We're going to be talking about the middle cerebral arteries, the vertebral and the basilar, and the posterior cerebral arteries. Those are the ones we're going to be going over. So when I talk about them, you have a general idea of where they are in the circle of Willis. So let's start with our anterior cerebral artery stroke. So with an anterior cerebral artery stroke, there's one thing you need to be looking for, and that's contralateral involvement of the feet and legs. This is the most common area to be involved. Contralateral meaning if it's the left anterior cerebral artery involved, the right leg or the right foot will be affected. There's obviously other possible presentations, urinary incontinence. It's possible to have weakness in the upper extremities, but most common, what's going to be on the vignette and what you need to focus on is going to be some kind of deficit in the lower extremities. So paralysis and sensory loss in the contralateral leg and foot. How do you remember that? So this is how you remember. As soon as you see anterior cerebral artery stroke, you think of ANT, ant, and you think of an ant. Most commonly affects contralateral leg and foot. When you see an ant, what do? When you see an ant, you lift your leg and you step on it with your foot. So as soon as you see anterior cerebral artery stroke, you think of an ant, you lift your leg, step on it with your foot. That helps you remember anterior cerebral artery stroke commonly affects the contralateral leg and foot. Anterior cerebral artery stroke, again, ant, step on it with your foot, lifting your leg, stepping on it with your foot. That's the area it most commonly affects. All right, that's anterior cerebral artery stroke. Let's move on to middle cerebral artery stroke. This is going to be contralateral arm and face and aphasia. So the one thing you also need to know about middle cerebral artery stroke is it's the most common artery to be involved in an ischemic stroke. So if they ask you what is the most common artery to be involved in an ischemic artery stroke, an ischemic stroke, that's going to be your middle cerebral artery stroke. Remember that because middle cerebral artery, MCA, most common artery. That helps you remember that. You'll never forget that, and that's nice and easy. So middle cerebral artery stroke, what you're looking for in the vignette is contralateral face and arm involvement and aphasia. So paralysis and sensory loss will be greatest on the contralateral side of the face and the arm versus the lower extremities, as well as aphasia in a middle cerebral artery stroke. Remember, aphasia is difficulty producing or understanding speech. So the way that you remember that is instead of the MID, the first three letters in middle cerebral artery stroke, you change it to MAD, like as in mad. You remember middle cerebral artery stroke. And what do you do when you're mad? Well, you probably don't do this, but in cartoons they do. So when you're mad, you lift your arms up in the air, your face gets red, and you yell. So that helps you remember. If you're mad, you lift your arms, because remember, it most commonly affects the contralateral arm. You get red in the face. Remember, most commonly affects the face. And you yell. So aphasia. So yelling helps you remember. It affects the voice, and that helps you remember aphasia, which is, a problem with difficulty producing or understanding speech. So not necessarily that you're going to yell, but that helps you kind of guide you back to aphasia. So remember, middle cerebral artery stroke. Remember, middle cerebral artery stroke. You're mad. You lift your arms in the air, your face gets red, and you scream out. You're mad, you lift your arms, most commonly affects the arms, get red in the face, affects the face, and leads to aphasia, you're yelling. That helps you remember your middle cerebral artery stroke. Now let's talk about the posterior circulation. So specifically the posterior cerebral artery and the vertebrobasilar artery that I'm going to go over. In general, if they mention any visual changes, you should be thinking somewhere in the posterior circulation. I wanted to break it down a little bit further, talk about some of the different vessels, and then some of the unique presentations seen with each. So let's first start with our posterior cerebral artery stroke. Two things you need to know in a PCA stroke that you should be aware of for the exam. First one is going to be something known as homonymous hemianopia. So one thing about this is that they'll normally mention, or they may mention, that it spares the macula. The reason, this is a little bit of extra knowledge you probably don't need to know, is it's because the macula is normally perfused from the collateral flow from the middle cerebral artery. So you'll have homonymous hemianopia, generally sparing the macula with PCA stroke. This can also be seen in a middle cerebral artery stroke as well, but it's much more common in a PCA stroke, and if you're going to see it in a vignette, they'll likely be talking about posterior cerebral artery. What it is a visual field defect involving the contralateral side. So either the two right or the two left halves of the visual fields of the eyes are affected. So basically half of your visual field is not being processed. It's blacked out visual field on the contralateral side. We can take a look at what that looks like. So you can see half of the eye can see, you know what I mean? Like on this half, you can see. The other half, nothing. You have no visual field on the opposite side. The other thing that commonly comes up with posterior cerebral artery stroke is something known as alexia without agraphia. So this means they cannot read, but they can write. So they can write you a whole story, but they can't read it back to you. So that's alexia without agraphia. The way that I used to remember these two, these are kind of silly, but they might help you. So with posterior cerebral artery stroke, as soon as I see posterior, I think of a P, and I think of how glasses kind of look like P's, like they look like two big P's, as we can see like here with this girl. They look like two P's, so that helps me remember posterior cerebral artery stroke. Vision is affected, homonymous hemianopia, two P's is glasses. And then the other thing is with posterior cerebral artery stroke is alexia without agraphia. I think of Alexa, which is, I'm sure we've all heard of Amazon Alexa, and I remember that Alexia is your personal computer assistant. Posterior cerebral artery, PCA, personal computer assistant. Alexia, I know it's Alexa, but it helps you remember Alexia without agraphia. PCA, personal computer assistant. So that's how I remember those couple. Hopefully that helps. And then vertebral basilar artery stroke. This one's nice and easy because vertebral basilar artery stroke starts with a V. All of the things you're generally going to see in a vignette about vertebral basilar artery stroke start with a V. So vertigo, visual changes like diplopia, vomiting, and vibrating eyes, as I call it, which is nystagmus. If you look at nystagmus, it's like kind of like the eyes shaking, like vibrating. So remember that. These are the ones you'll likely see in the vignette. Vertigo, visual changes, vomiting, vibrating eyes, nystagmus, all starting with V's, vertebrobasilar artery stroke. And that is your clinical manifestations for ischemic stroke. Those are the main things that you need to know that will likely get you the question right. Let's talk about diagnosis. So diagnosis, this is obviously going to be very similar to the TIA workup. We're just going to go into a little bit more detail. So in making the diagnosis in a patient with suspected stroke, the initial test, like right when the patient comes in the door, you're going to do a finger stick blood glucose, you're going to check their oxygen saturation, and you're going to do a non-contrast CT. Those are your main diagnostic tests to guide acute therapy. Finger stick's really important. You want to make sure this patient doesn't just have hypoglycemia, because hypoglycemia can actually lead to focal neurologic deficits that mimic the presentation of stroke. So you have to rule this out. You can imagine giving somebody TPA that just had low blood sugar. That would be ridiculous. You would lose your license instantly. So anyways, let's talk about diagnosis. First, CT head non-contrast. This is the one you'll likely see on the vignette. This will likely be the correct answer, but let's talk about it. So non-contrast CT of the head in any patient you suspect a stroke. This is your initial test of choice. So is a CT of the head used to make the diagnosis of an ischemic stroke? It's actually not, and that's a common misconception. The main purpose of a non-contrast CT is to tell us one thing. Is there blood? Is there no blood? Is this a hemorrhagic stroke or is it not? Because if there's blood present and this is a hemorrhagic stroke, we know reperfusion therapy, like with TPA, is off the table. So again, CT initial test of choice, basically used to guide your treatment in regards to TPA and let us know whether or not this is a hemorrhagic stroke. It can pick up some early signs of acute ischemic stroke, but really the best way to look for acute ischemic stroke is going to be with your MRI. MRI, like I talked about in TIA, it's a better test than a CT. It does a much better job at detecting acute infarction. The reason why we more commonly use CT, like I talked about before, is MRI is time-consuming, CT just takes a few minutes. MRI is not available at every institution. MRI has a bunch of contraindications. So MRI is better, but not used as often as CT. So CT is normally going to be your answer. So once you've done your neuroimaging, you've done your finger stick, make sure this patient doesn't have hypoglycemia. You have some additional tests as part of your workup. These aren't as important, but you need to know about them. So EKG. So you want to get an ECG because you want to know, does this patient have an arrhythmia like AFib, a flutter that may have been the cause of an embolic stroke? If this is the case, this patient is likely going to be started on anticoagulation to prevent future strokes. You want to get an echo because you want to make sure that this patient doesn't have a cardiogenic or aortic source for cerebral embolism. So basically you're looking, is there another bullet left in the chamber? Does this person have another clot in the heart that could potentially lead to another stroke? Is there vegetations on the heart valves from endocarditis, other risk factors and things like that? That's what you're looking for on your echocardiogram. Neurovascular imaging, CTA, MRA, main thing that you're looking for here, like we talked about in TIA, is a large artery occlusion. You want to make sure this patient isn't a candidate for a mechanical thrombectomy. So be aware of those ancillary tests, your echo, your EKG, your neurovascular imaging, but the main diagnostic test, that's your non-contrast CT. That's what you get when they first come in. That's what you'll likely be asked in a vignette. Treatment. So treatment in an acute case of ischemic stroke. There's two things that you need to know for treatment. That's TPA, that's the big one, and mechanical thrombectomy. So let's talk about thrombolytics, Alteplase, TPA. So Alteplase is a thrombolytic drug. It's a clot buster. It's first-line therapy for acute ischemic stroke patients if it's initiated within 4.5 hours of symptom onset. After 4.5 hours, the risks outweigh the benefit, and it's just not worth giving it anymore. There's some exceptions to that time I'll talk about in a minute, but most patients are going to be within that 4.5 hours of onset. Of course, assuming that they don't have any contraindications to TPA. There's a whole laundry list of contraindications for TPA. I don't expect you to memorize them, but if you want to remember a few of the important ones, what you're going to do is instead of remembering TPA, you're going to add a couple letters. Instead of TPA, you're going to do TPAIN, aka the rapper T-Pain. I'm going to buy you a drink. And remember, T-Pain is 45. Is T-Pain 45? I don't know. He's probably close to that. So you remember, TPA contraindications, T-Pain is 45. That helps you remember some of the big contraindications for TPA if you wanted to remember some of them. So T, trauma to the head in the last 3 months. So any kind of severe head trauma in the last 3 months. P, platelet count less than 100,000. A, active internal bleeding. I, intracranial hemorrhage ever. Neurosurgery is the N, which is in the last 3 months. So any type of intracranial or intraspinal surgery. I, intestinal malignancy or intestinal hemorrhage in the last 21 days. And then the last S stands for stroke, specifically ischemic stroke in the last 3 months. And then 45 stands for 4.5 hours. Let's talk about the 4.5 hours a little bit more. So there's a few warnings, but not absolute contraindications to the 4.5 hour window. So you have to weigh the benefit versus risk. So in certain patients, this 4.5 hour window, it's cautioned that maybe it should drop to only 3 hours. So the cases are going to be if they're over 80, if they have a severe stroke classified by the NIHSS score, if they're on anti-oral anticoagulants, if they're on oral anticoagulants, or they have a combination of both a previous ischemic stroke and diabetes mellitus, then generally it's safer to give it within 3 hours. So those aren't absolute contraindications, but they are caution. But majority of patients are going to be able to follow that 4.5 hour window. Let's talk about the second treatment. That's going to be a mechanical thrombectomy. So a mechanical thrombectomy, what happens is you have either interventional radiologist, you have a surgeon, goes in and literally just pulls the clot out. It works really well. It can be done up to 24 hours compared to the 4.5 hour restriction with TPA, but this isn't for every patient. Keep in mind, not every hospital is equipped to perform this type of procedure, and you can only do this in patients that have a large artery occlusion in the anterior circulation. Other patients are not going to be eligible for this type of procedure, and this is just to kind of get an idea of what it is. They go in and they just pull the clot out, which obviously has a lot less risk than TPA. TPA has a ton of risks. So if you can do this, if they have a large artery occlusion in the anterior circulation, this would be a great way to remove it. But not every patient can have this done. So that's your other type of treatment. Likely you'll be tested on TPA, though. That's more common. Let's talk about blood pressure for a minute. So blood pressure is interesting with an ischemic stroke because it goes against most of the things that we know as far as treatment for blood pressure. So you don't touch the blood pressure in most patients with an ischemic stroke unless it's over 220/120 or you're giving them TPA, and then in which case you want to have it less than 185 over 110. So blood pressure in patients with ischemic stroke, if they're getting TPA, you want their blood pressure less than 185 or less, and their diastolic blood pressure 110 or less. That wasn't in the mnemonic, so just be aware of that as well. If they're not getting TPA, you can actually let their blood pressure ride all the way up to 220 over 120 before you have to intervene. So why is that? Well, think about it. So you have this clogged up cerebral artery. There's not much blood getting past this occluded area, and perfusion pressure distal to that obstructed vessel, it's really low. So this elevation in blood pressure is actually helping to maintain brain perfusion past this point in those ischemic areas. So the high blood pressure is actually helpful. So most of the time you don't want to turn down the pressure in an ischemic stroke, except for those exclusions we just talked about. All right, let's talk about some of our adjunct or long-term management. So in addition to TPA, thrombectomy, there are some interventions for ischemic stroke to reduce complications, stroke recurrence. So the first one, antiplatelet therapy, so aspirin, clopidogrel. If they didn't get TPA, they're going to need antiplatelets. Generally, aspirin 325 milligrams. If they had TPA, you have to wait at least 24 hours to give them antiplatelets. And then statin therapy is another big one. This one's really important. There's clear evidence that long-term intensive statin therapy is associated with a reduced risk of recurrent ischemic stroke. And then, of course, like I went over with TIA, you're going to have your lifestyle changes, your smoking cessation, exercise, weight reduction, controlling blood pressure, diabetes, etc. I just realized a couple times when I was trying to say TIA, I may have said TPA. So if I did, I don't know if I did, but I think I may have. You'll know what I was talking about. All right, so those are most of your treatment options, the ones that you need to know for your ischemic stroke. So those are the ones I would focus on, and that is your ischemic stroke in a nice, easy way to remember most of the main things that you're going to be tested on. So let's move on to our intracranial hemorrhage, our hemorrhagic strokes. So I wanted to briefly touch on some of the types of intracranial hemorrhage, including some of the causes of hemorrhagic strokes. I'm going to focus just on the basics, the unique things, give you some mnemonics. Diagnosis for these is pretty similar across the board. It's going to be CT in most cases, some exceptions where you'll get a lumbar puncture I'll talk about. Treatment is generally not going to be tested on, but it can range from supportive measures, clips and coils, all the way to craniotomy in some severe cases. So let's start with our epidural hematoma. So epidural hematoma, this is bleeding between the skull and the dura mater. Epidural hematoma is a collection of blood that forms between your skull and the dura mater. Middle meningeal artery. So bleeding typically arises from the middle meningeal artery and normally is associated with a temporal skull fracture, particularly in children where this is more common. You need to know about your lucid intervals. So in the vignette for an epidural hematoma, they're almost always going to mention the patient had this loss of consciousness and then it was followed by this lucid interval where they had this transient recovery, this lucid interval where they got better for a period of time. That's the key to look out for in the vignette. I always saw that when I had a question about an epidural hematoma. And then as far as your CT findings, you're looking for a convex shaped bleed. So the bleeding will have this kind of outline or surface that's curved like the exterior of like a circle or a sphere. So really from the epidural hematoma, there's three things that you have to know. You have to remember your middle meningeal artery tear. You have to remember the convex bleeding and how to recognize it on a CT image. And you need to remember that lucid interval. The way that you remember that is as soon as you see epidural hematoma, epi, so EPI, if you rearrange those letters, that spells pi. So as soon as you see epidural hematoma, I want you to think of pi. When you think of pi, I want you to remember, a Lululemon pie. A Lululemon pie. So I'm sure we've all heard of Lululemon. It's like the athletic company that makes the yoga pants and everything. So that's where Lululemon comes from. Anyways, epidural, EPI, rearranged spells pie. Think of a Lululemon pie. So what does this stand for? So MMA stands for middle meningeal artery. Remember, that's the most common artery to be affected. So middle meningeal artery. Lulu stands for lucid interval. So LU, lucid interval. Remember that lucid interval, that is really important. And then lemon pie. So lemon is because when you look at a CT of an epidural hematoma, you can't tell me this doesn't look like the outside of a lemon. So that's why I say lemon pie, because when you get a CT image and you see this, you're going to right away think that looks exactly like the side of a lemon. And then you remember, a Lululemon pie. So remember, epidural hematoma, EPI rearranged spells pie, a Lululemon pie, middle meningeal artery, lucid interval, lemon or convex shaped bleed on the CT. All right, so that's epidural hematoma. If you remember that mnemonic, I'm pretty sure you're going to get the question right. Let's talk about subdural hematoma. So subdural hematoma is bleeding that forms between the dura and the arachnoid membranes overlying the brain. The bridging veins tear is really important. So an acute subdural hematoma is usually caused by tearing of the bridging veins located between the arachnoid membranes and the dura. So bridging veins, remember that. Elderly and alcoholics. So in a vignette, the patient will likely be elderly or an alcoholic who had some kind of trauma, a fall, a motor vehicle accident. The reason why we see this more commonly in this patient population is because cerebral atrophy is common in both older adults and those with a history of chronic alcohol abuse. So cerebral atrophy results in a larger space between the dural membrane and the cortical surface of the brain. And what happens is that increases tension on these bridging veins. You can think of like a space that's kind of stretched out. If you had like a vein in between two areas and that area stretched, so what happens is when these patients fall or have a traumatic brain injury like in an MVA, these bridging veins are more susceptible to tearing because they're stretched and pulled across this greater distance. And that's why elderly and alcoholics, you'll see these likely in the vignette when they're talking about it because of the cerebral atrophy. CT findings, you're going to have a crescent-shaped hematoma. So crescent-shaped appearance because the bleeding follows the contour of the overlying dura, and it looks kind of like a crescent moon. So how do you remember subdural hematoma? 4 things that you need to know. So you remember subdural hematoma. Instead of subdural hematoma, you remember subdural hematoma, D-O-O-R. That stands for drunk old, because remember, that's going to be the patients you'll see in the vignette. Stands for overpass, because an overpass is just another name for a bridge. That helps you remember your bridging veins. And then the R is the second letter in crescent, because you have a crescent shape on the CT. That's what it looks like on a CT. You can see it looks like a crescent moon, like a crescent shape here, just on the outlet, the lateral border of the brain. So that is your subdural hematoma. Remember, subdural hematoma, drunk old overpass crescent. All right, let's move on to our subarachnoid hemorrhage. So a few things you need to know about subarachnoid hemorrhage. So subarachnoid hemorrhage is an extravasation of blood into the subarachnoid space between the pia and arachnoid membranes. So you're bleeding within the meninges into the ventricles. Let's look at an image here. So you can see blood into the fissures. You can see blood into the suprasellar cistern. This isn't going to be on the lateral borders like we saw in epidural and subdural hematoma. This is going to be more kind of diffuse. So this is what a subarachnoid hemorrhage looks like on a CT. So be aware of that as well. Berry aneurysm rupture, most common cause. So rupture of a berry aneurysm, which is also known as a saccular aneurysm. You may see that in the vignette instead of described that way. That's going to be your most common cause of a subarachnoid hemorrhage. Severe headache, meningeal symptoms. So worst headache of my life. So subarachnoid hemorrhage has a very specific clinical presentation, and I'm sure most of you have heard this before, probably even before PA school. So a patient with a subarachnoid hemorrhage will often describe having the worst headache of their life, also known as a thunderclap headache, because all of a sudden they're going to have this severe headache. It's not an insidious onset. It's patients feeling completely normal, and then they have a 10 out of 10 headache in a matter of minutes. Meningeal symptoms is important as well because it's pretty unique. So these patients may have symptoms of meningeal irritation, also known as meningismus. So you're going to look out for your nuchal rigidity, your photophobia, your lower back pain. It can occur in as many as 80% of patients, and it's from the breakdown of blood products into the CSF, and this leads to an aseptic meningitis. Lumbar puncture, xanthochromia. So you're of course going to get your CT like you did in all other types we went over, but in a patient with a negative CT that you really suspect may have a subarachnoid hemorrhage, you have to go further. You have to get a lumbar puncture. This is going to be on your vignette. And what you look for in the lumbar puncture is xanthochromia. And that's this yellow tinged CSF, which is from bilirubin in the CSF, indicating old blood. So if both the CT and the LP are negative, you've essentially ruled out a subarachnoid, but you need both to say definitively in patients with high clinical suspicion. You can't miss this in real life because the problem is this can be fatal. So if you do a CT, it was negative. CT is very dependent on time with a subarachnoid hemorrhage. Later on, it's not as common to pick up findings on a CT. So you have to do a lumbar puncture as well if you suspect a subarachnoid hemorrhage. So that's important to know. Intracerebral hemorrhage. There's very little to know for this. There's not much unique about it, and therefore there's probably not a lot to know for the exam. You may not even be tested on it. But intracerebral hemorrhage, it's bleeding into the brain parenchyma. It's the second most common cause of stroke after ischemic stroke. And then you want to look out on the vignette for older age plus hypertension. So the risk of intracerebral hemorrhage increases with advancing age. In addition, the most common etiology of a spontaneous intracerebral hemorrhage is hypertension. So look out for that. Elderly patients and hypertension. Those are the main ones, but there's some other common causes. They may mention amyloid angiopathy. They may mention ruptured vascular malformation, but focus on hypertension. That's your most common etiology. Looking at a CT, it's pretty simple. You're just going to see a bleed into the brain parenchyma. So anywhere in the brain parenchyma, you can see a bleed. Not very specific CT finding. This may not be on your exam. They're probably going to give you a subdural or an epidural because those are so specific, the CT images for those. So it's probably what you'll get if you get an exam question on that. So that is stroke. I feel like that was enough for you to get most of your questions right. Let's do a few questions to see what you've retained. So let's test your knowledge. Question 1. So a 67-year-old male with history of hypertension and hyperlipidemia arrives to the emergency department accompanied by his wife and daughter. His family members state he is unable to speak and has not been able to lift his right arm. When you ask the patient to puff out his cheeks and smile, you note prominent drooping on the right side of the face. Patient likely has a stroke of which cerebral artery? So that is going to be your middle cerebral artery, left-sided specifically, as we see contralateral involvement of the right upper extremities, right side of the face, and aphasia. Remember, instead of middle cerebral artery, remember maddal cerebral. You're mad, your arms are up in the air, you're red in the face, and you're yelling. Helps you remember this patient has involvement in the arms, the face, and aphasia. That is your way to remember that. So question 2. 63-year-old male presents to the emergency department complaining of neck stiffness and a sudden onset severe headache unlike any other he has had before. His past medical history includes only hypertension. While speaking to him, you notice he is squinting his eyes and asks if you can dim the lights. You order a CT of the head, which is negative. Which additional test should be performed for the suspected diagnosis? So that is going to be a lumbar puncture. So this patient has a history of a severe headache, which he describes came on suddenly. That's our thunderclap headache. In addition, he has meningeal symptoms, photophobia, nuchal rigidity. No history of migraines, so we need to suspect a subarachnoid hemorrhage in this patient. Start with your non-contrast CT. If that's negative and you have a high suspicion for subarachnoid, which we do in this patient, you need to order your lumbar puncture to make sure that they do not have a subarachnoid hemorrhage, which can be fatal. And then in the lumbar puncture, you're looking for your xanthochromia, which is from the breakdown of red blood cells in the CSF. Question 3, a 76-year-old male accompanied by his daughter has been diagnosed with an acute ischemic stroke. His blood pressure is 168/92, oxygen saturation 96%, pulse 88, temperature 98.3. He was known to be well 2 hours ago when his daughter spoke to him by phone. She states he has a history of hypertension, type 2 diabetes, and celiac disease. She is very worried about him, saying this is his second stroke in the last 3 months. Would this patient be an ideal candidate for TPA? If not, why? And the answer is no, because he has a history of ischemic stroke in the last 3 months. So ischemic stroke in the last 3 months is part of the exclusion criteria for IV thrombolysis, TPA. It's one of the many. Again, I don't expect you to remember all of them, but if you can remember that T-pain is 45, you can remember the important ones, which would include this patient here that has an ischemic stroke in the last 3 months. Question 4, which artery is the most common to be involved in an ischemic stroke? That's going to be your middle cerebral artery. Remember, middle cerebral artery, MCA, most common artery, in around 70% of the cases. Question 5, last question. A patient being treated for ischemic stroke is greeted by the treating physician or physician assistant, who informs him they're going to administer a medication called nicardipine into his IV to start lowering his blood pressure. He is unable to receive TPA due to gastrointestinal malignancy. The blood pressure in this patient has likely exceeded what systolic and or diastolic level? So that would be systolic over 220 and or diastolic over 120. So for patients with ischemic stroke who are not going to be treated with thrombolytic therapy, and we stated this patient is not a candidate due to a GI malignancy, so we don't have to worry about those specific BP guidelines. This patient should not have their blood pressure treated acutely unless the hypertension is extreme. That's going to be a systolic blood pressure over 220 and or diastolic blood pressure over 120. Remember, in patients with ischemic stroke, the perfusion pressure distal to that obstructed vessel is low, so we need to keep the pressure high enough to maintain brain perfusion, but this patient likely had a blood pressure over these guidelines, and that's why he's going to be treated. So that is the questions. Hopefully you got those right, and hopefully this video was helpful. As always, thank you so much for watching the videos. Thank you for the great comments, all the new likes, subscriptions. I appreciate all of it, and good luck in PA school, your PANCE, your PANRE, your EORs, and thank you so much again for watching the video.